Welcome to the Deep Dive. Today, we're tackling a really crucial question in healthcare. How do we actually measure quality? It seems simple, but it's really not.
It's definitely not simple.
We've got this foundational paper, Tang and colleagues from 2007, and it reveals some, well, pretty surprising things about what we think we know.
Yeah, it really does. And our goal here, really, is to understand why the kind of data we use makes such a huge difference, especially for you, the patient, now that these pay-for-performance programs are becoming more common.
Pay for performance, right? Where doctors and hospitals get rewarded for quality.
Exactly. So we need to be sure we're measuring the right thing, seeing the true picture of care, not just, a fuzzy outline based on convenient data.
Okay, so historically, how did we measure it? You mentioned convenience.
Well, for a long time, a lot of these quality metrics relied heavily on administrative claims data.
Claims data. You mean billing codes, stuff submitted for payment.
Precisely.
Yeah.
Billing codes is often the only data available on a large scale, so people used it.
But data collected for billing. That doesn't sound ideal for judging clinical quality, does it?
Not at all. And that's what's so eye-opening here. It wasn't designed for clinical nuance. Think of it like trying to judge a chef's skill only by looking at their grocery receipts. You miss the actual cooking, the taste, the presentation.
Right. You miss the actual care.
This study really highlights the blind spots claims data creates. The care a doctor actually provides might just not show up accurately in those billing codes.
So this Tang study, they decided to compare things directly.
They did. They really dug into it. They compared that administrative claims data with clinical data from electronic health records, EHRs.
Okay, EHR, so the actual digital patient chart.
Exactly. Pulled from EHRs from Medicare patients who had diabetes, and crucially, they had a gold standard.
Gold standard?
Yeah, they had experts manually review the patient charts, like read through everything to determine who really had diabetes and what care they actually got. That was their benchmark for truth.
Makes sense. So what happened when they compared claims data to that gold standard?
The results were pretty stark. Claims data, using a really common method, this two-visit diagnosis rule.
Meaning you needed 2 separate doctor visits with a diabetes code build.
Yes. Using that rule, claims data only identified 75% of the patients who truly had diabetes, according to the expert chart review.
Wait, 75%? So 1 out of every 4 diabetic patients was just
Dismissed.
invisible to that quality measure.
Invisible, just based on how the billing happened or didn't happen in that specific matter.
Wow, that's not just a small error margin. That feels huge.
It is huge. And think about the implications for measuring quality if you're missing a quarter of the relevant patient population.
Okay, so then how did the EHR data stack up, the clinical data from the charts?
Now that's where it gets really interesting. Using coded clinical data straight from the EHR.
Like what kind of data?
Things like the patient's official problem list, where diagnoses are recorded, or their medication lists, or actual lab results, like blood sugar tests.
Right, the stuff clinicians actually use day to day.
Exactly. Using that data, identified 97% of the diabetics confirmed by the chart review.
97%. Okay, that's a massive difference, from 75% to 97%.
A huge accuracy leap. And this wasn't just about counting heads, counting patients correctly. It had real downstream effects.
So it actually affected the quality scores themselves.
Absolutely. This difference in who was counted led to statistically significant differences in the measured quality of diabetes care. Take those patients who were missed by the claims data, the ones with fewer than 2 coded visits. They were far less likely to get recommended care.
Like what? Give me an example.
Okay, HbA1c testing. That's a key test for long-term blood sugar control. For those invisible patients missed by claims, only 68% got the test.
68%.
Compare that to 97% for the patients who were identified by the 2-visit claims rule.
Wow, that's a gigantic gap in measured care.
Huge gap. And they saw similar disparities for things like blood pressure control, tests for kidney problems, eye exams, all crucial parts of diabetes care.
So the takeaway is, using the wrong data doesn't just give you a slightly fuzzy picture, it can give you a completely misleading one.
Precisely. Inaccurate data leads to inaccurate, potentially misleading quality reports. And that has consequences.
Consequences for who? Hospitals, doctors, patients.
All of the above.
Yeah.
If you connect it to the bigger picture, relying only on claims data can systematically bias these reports. You might think performance is better than it is, or you might focus improvement efforts on the wrong areas because the data isn't showing the real problems.
Which ultimately impacts patient outcomes, right? If we're not improving the right things.
Exactly. It affects real care for real people.
So the paper obviously argues we need to move beyond just Claims data.
Strongly. It makes a very compelling case.
But that sounds like a big shift for the healthcare system. What's the proposed solution?
The clear path forward is to shift quality measurement towards using clinically based measures, leveraging that rich coded data that's already in the EHR.
The data that gave the 97% accuracy rate?
Right. It's more accurate, it gives a truer picture of the care provided, and bonus, it could actually reduce the reporting burden on doctors and hospitals because they're using data already captured during care.
Instead of separate reporting just based on billing codes?
Exactly. But this shift needs support. Policymakers really need to design incentive programs, the pay-for-performance rules, to encourage and reward this transition to EHR-based clinical measures.
To make sure the measures truly reflect patient care.
That's the goal, a true patient-centered reflection of care quality.
This deep dive really underscores it then. Accurate data isn't just a technical detail, it's fundamental for effective healthcare. It really matters for all of us.
Absolutely. Imagine a system where the quality measures really truly track your care journey, using the information from your actual health record. That kind of accuracy could drive constant, meaningful improvements. So thinking about this, what really stands out to you about how simply changing the data source can reshape our whole view of health and healthcare?
That is a powerful question to think about. Thanks for joining us for this deep dive.